Good afternoon, everybody. I'm Erica Trappel, and on behalf of the Prevention Research Center for Healthy Neighborhoods at Case Western Reserve University, I'd like to welcome you to our monthly research seminar series. Today, we'll be hearing about Nourishing Beginnings, a community academic partnership to address food insecurity and improve maternal health and birth outcomes in Medicaid-eligible pregnant individuals. If you've not joined us before, we encourage you to connect with us through Facebook, Twitter, LinkedIn, and all of our seminars are recorded and shared on our YouTube page at Cruise PRCHN. You can also learn more about what we do at www.prchn.org. For next month, we just like to introduce this ahead of time. We'll be inviting Dr. Georges Khalil, who will come and talk about games for health from personal to social impact. We're going to put that link in the chat box for you today, so I encourage you to register and join us again in March. And because we are maintaining our virtual gathering, we do miss out on seeing one another, but we encourage you to connect by introducing yourself in the chat box today by adding your name and your organization so that you also know who else is joining us on the call today. We're going to use that chat box for the Q&A feature. Our seminar moderators will keep an eye on that. And we, after the presentation, we typically encourage you to come off of mute, come onto the camera and use the raise hand feature so that you can actually engage with our presenters. So with that, I'm very excited to introduce our speakers for today, Dr. Elaine Borawski, Dr. Meredith Goodwin, and Ms. Alyssa Glenn. So just a little bit about our speakers. Dr. Borawski is the Angela Bowen Williamson Professor of Community Nutrition and the Vice Chair for Applied Research in the Department of Nutrition here at Case Western Reserve, and is the faculty lead of the Community and Collaboration component of the Clinical and Translational Science Collaborative. She's a medical sociologist interested in the social and environmental influences of health and health behavior, and has nearly 30 years of community-based research experience, most of which has been carried out at the PRCHN. She has served as PI of several NIH and CDC-funded community-based intervention trials with large interdisciplinary teams and community stakeholders as research partners. And she is the principal investigator for the Nourishing Beginnings study that we'll hear about today. Dr. Goodwin received her PhD in epidemiology and biostatistics here at Case Western Reserve University in 2003. Throughout her career, Meredith has worked with interdisciplinary teams on several large community and practice-based research initiatives in both public health and medicine. She's a research scientist in the Department of Nutrition and at the PRCHN, and has served as the team science coordinator for the community and collaboration component of the CTSC. Dr. Goodwin is a co-investigator in the Nourishing Beginnings project, overseeing the day-to-day coordination of research activities. And finally, Ms. Glenn. Ms. Glenn serves as the Director of Community Health and Nutrition at the Greater Cleveland Food Bank. Alyssa leads the food bank's work at the intersection of food and health, including building partnerships with the healthcare providers and managed care organizations, leading research on the effect of food interventions on food insecure populations, and overseeing nutrition education initiatives. Alyssa is currently pursuing a PhD in urban policy with a research focus on food policy. She has a Master's of Science in Public Policy and Management from Carnegie Mellon University and a bachelor's degree in economics and English from Case Western Reserve University. Alyssa is co-PI for Nourishing Beginnings and oversees the food bank's intervention component of the program. I am so excited to see this presentation today. With that, I will stop sharing and hand it over to the Nourishing Beginnings team.
Okay. Thank you so much, Erica. All right, I'm going to share my screen. Let's see if this will work. Oh, you don't need to see that. Hang on, let me pull this back up again. Okay. Sorry, no matter how many times you practice this. Okay, let's try this again. Okay. And then. All right, so do you see a full slide?
We sure do.
Okay, get you over here. All right, well, welcome. Thank you all for coming and joining us today. I think for those of you who have not heard about Nourishing Beginnings, and we like to talk about it. So this is a really fun opportunity to tell everybody a little bit more about it. And we do want to, you've met the co-investigators and co-PIs of the project with Meredith Goodwin and Alyssa Glenn. We do want to also acknowledge Christopher Mundorff, who is with Better Health Partnership, and as you'll learn, is one of our primary partners in Nourishing Beginnings. And along with that, in acknowledgements, what you'll see is that this is probably one of the really most exciting community academic partnerships that I think that I've been involved in for a long time. It's a truly an equal partnership. As you see, we are considered co-PIs on this project together, and it brings together the Greater Cleveland Food Bank, Better Health Partnership, and its Community Health Worker Hub, those of us at CASE and at the PRC, and then a host of community health worker partner organizations that you'll learn more about in a minute here. And we are very grateful for the funding that we have. It has been sort of slowly coming. We've been very graciously supported by Vitamix Foundation and the Bruning Foundation, and through the Clinical and Translational Science Collaborative, or the CTSA here at CASE. And more recently, and we'll tell you a little bit about it at the end, we've just recently received funding from Robert Wood Johnson and CareSource of Ohio. So a lot of exciting things happening. So I'm going to switch it over to Alyssa, and she's going to introduce the project, and we'll move from here. So Alyssa, take it from here.
Thanks, Elaine. Hi, everybody. Happy Wednesday. Thanks for joining us. I'm going to start with some information about the food bank and a little bit of information about food insecurity and health outcomes. So just to start, a little bit about the Greater Cleveland Food Bank and food banks in general. We are one of 12 food banks in Ohio. Ohio is covered every county by one food bank. So we cover 6 counties. And just to give you a size of our scope, we serve about 300 to 400,000 unique people in our 6 counties every year. So we serve those people through various types of feeding programs. We have food pantries that we serve, of course. We have hot meals coming out of our kitchen. We serve a quite large number of people through mobile pantries or produce distributions. And then we also have an increasing number of healthcare partnerships. And all of that adds up to about 50 million pounds of food that we're putting out into the community every year. So there is a big difference between a food bank, especially some of the larger food banks, and we're in that larger category, and a food pantry or a single service point. So across that service territory that we serve, we are providing food. We're a centralized food provider to about 1,000 different programs and partnerships across that 6 counties. So a little bit about our food. We get food through a variety of different sources. A significant amount of that food comes through government partners. A lot of it comes from the USDA, or what we call TFAP food. That stands for the Emergency Food Assistance Program. And we also have a couple of large state contracts. One of these contracts provides us funding to buy food. Another provides a contract directly with Ohio farmers that provides surplus produce that Ohio farmers are growing. So that's actually a pretty unique partnership across the country, and it provides produce to all of the Ohio food banks. And that's one of the sources for a significant amount of that fresh fruit and vegetable that we're able to put out into the community. Then, of course, we also get donations, both from individuals, but also a significant number of donations from vendors, such as Giant Eagle, Orlando for bread, and then Costco. I mean, some of the really big suppliers also donate surplus food to the food bank. We also purchase a significant amount of food. Some programs, for example, feeding programs that serve kids, we have to purchase all of the food for that. And also just to fill in, if there are certain items that are high in nutrition, for example, olive oil, we can't get that through any of our other sources, so we'll purchase it. So all the donations that come into the food bank are really helpful for filling some of those gaps where we need to purchase food. And there is and has been a strategic focus for many years across the network of food banks to focus on the quality of our food. So when you look at that 50 million pounds of food, about 18 million pounds of it are produce in our past year, and another 9 million are perishable foods. So things like frozen chicken and proteins, frozen vegetables, dairy that is perishable. So there's, continuous improvement efforts to improve that quality that we're putting out to the community. What I focus on primarily at the Greater Cleveland Food Bank is what we call our Food as Medicine initiatives, and we have a large number of those. Some examples, we have Food as Medicine clinics. These are pantries that sit inside hospitals at the moment. So we serve Metro Health and university hospitals where they're screening for food insecurity among their patients and then referring those patients to these highly nutritious food pantries with the specific intent of improving health outcomes through that food service. We also have a number of mobile produce distributions that we do on site at healthcare providers. So when we're thinking about healthcare providers, we're talking about all of the hospital systems as well as FQHCs, and then additionally some other types of providers, for example, dialysis centers who are serving obviously people with kidney disease. There's a very strong relationship there with food insecurity and kidney disease, and so they're especially interested in mobile produce distributions. Another thing that's been growing quite a bit over the last few years is what we call screen and refer programs. Just about all of our major healthcare providers now have active efforts to screen patients for food insecurity. So then that next step of what do they do if they know the patient is food insecure, that's the referral. So we have multiple types of referral options for healthcare providers when they know that their patients are food insecure, so they can get that connection between them and the food bank, and we can refer them out to our various programs and try to improve their food security. We also do a lot of free nutrition education, about 1 per day out in the community. And those are meant to really help our partners encourage a lot of those healthy foods and build people's capacity to know what to do with some of the fresh produce in particular that we're putting out there. And then this next growing space is what I call food intervention research, and Nourishing Beginnings is an example of that. And then another thing that I just wanted to get out there is that there are policy shifts happening across the country as the knowledge around the relationship between social determinants of health grows among healthcare providers, but also some of the managed care organizations and public health entities like, at the state level, the departments of health. There are subtle policy shifts that are happening, some subtle, not so subtle, that are encouraging these interventions and building the body of research around what social determinant of health interventions look like. So one example in the state of Ohio is that the most recent contracts with managed care organizations actually mandate screening for food insecurity and building connections with community partners. So there's a boom of interest from those managed care entities in Ohio to make these partnerships. So food banks are trying to build their capacity and identify what works as far as these social determinant of health interventions. Next slide, please. Okay, this slide has some information about what we know about food insecurity and poor health outcomes. Food insecurity has been studied since about the early mid-1990s, from the point that there was a real definition out of the USDA for what food insecurity is. And since there is a definition and a screening tool, it has been studied. And so there's a fairly robust body of research that demonstrates this relationship between food insecurity and health. So we know, for example, that food insecurity is associated with poor health outcomes, and it's most well understood around chronic disease. So we know, for example, and these are really just examples because that body of research is pretty large, that if you're food insecure, you're more likely to develop heart disease, diabetes, and many other chronic diseases. We also know that once you're food insecure, it's more difficult to manage those diseases. So there's literature showing that if you're food insecure and diabetic, you have lower medication adherence, you have a higher rate of emergency room visits. And again, these are just really examples from that literature. We also know that there's a significant relationship between food insecurity and mental health, such as stress and depression. Then in Cuyahoga County, part of the the reason that this project got up and running is that we've known, and I'm sure I'm speaking to the choir here, that there's a very racially disparate rate of infant mortality in Cuyahoga County and in Cleveland. So Black babies are 4 times more likely to die in their first year than white in Cuyahoga County. It's even worse in Cleveland. The leading cause of infant mortality is premature birth. And we know that food insecure pregnant people are 2 times more likely to deliver prematurely. So there's also that strong relationship between food insecurity and negative mental health outcomes during pregnancy. And then additionally, in Cuyahoga County, we have just layered on factors that make it difficult for pregnant people to eat well and have positive health outcomes. We know we have a substantial percentage of the land is a food desert. We have very poor transportation options. SNAP, we know very well at the food bank, is not enough. So even when people are receiving SNAP, they have additional need. And by the way, the emergency SNAP allotments that took place during the pandemic are ending this month. So that's something important to know for anyone who's working with people who receive SNAP. If you received the emergency allotments, which everybody who did, your SNAP dollars are going to drop down on average $100 per month at the end of this month. So that's going to increase food insecurity even more after the end of this month. Okay, I think, am I turning it over to Elaine at this point?
No, keep going.
Okay. All right. So a little bit of background on the program. This program was really born out of some COVID-specific work that we were able to do. So in the heat of the pandemic, or the first part of the pandemic, First Year Cleveland, which was originated to really address some of the infant mortality disparities in this region, made some connections with the food bank to deliver food directly to either pregnant people or to coordinate that delivery with community health workers. So this was something that we weren't able to do previously, but because of some of the additional assets that we received during the pandemic, we were able to begin. We had a lot of success and a lot of positive feedback from that. The pregnant people who received the food were very happy about it. And we also received feedback from the community health workers that having that food, if they were able to coordinate it, was a really good way to increase the likelihood that people were attending those appointments with community health workers. It was just a positive thing to bring to that interaction. So when we received this feedback, the question was, can we make this a sustainable program? But it wasn't studied, as many things aren't, especially during that pandemic when we were just operationalizing things right away. We didn't have any real measurable data to prove that that food delivery that was so successful was resulting in any type of change that managed care would hope to fund. Next slide, please. So this is where the Pathways Hub comes in. Better Health Partnership is a centralized type of entity meant to improve population health. So it took me a while to really understand what BHP is, and what it is really is centralized billing. And this is also a kind of unique asset that Ohio has policy-wise, that Better Health Pathways Hub is able to bill for community health workers who are employed at a variety of different community organizations. So it's a path towards sustainability for the work that community health workers do. And they're able to do the work along various pathways that are defined in the hub. So pregnancy is a pathway. Postpartum is a pathway. So if you partner with the hub, you are able to have sustainable funding for work along those pathways. So this was a really good opportunity for partnership on the part of this work, because we think that community health worker component is really important. And if we can build this out and show that the interaction of the community health worker along with the food provides an effective nutrition intervention, then it's sustainable through that funding, through Medicaid, through the hub, for a variety of different organizations. So everything from grassroots types of organizations that are just focusing on pregnancy health, all the way through the bigger hospitals that are starting to employ more community health workers now. Okay. Elaine, am I passing it off to you?
Yeah, now you're passing it. Yeah.
Okay, all right.
Thank you, Alyssa. That was an awesome front edge, because I think that every time I hear you even talk about what the food bank does, I learn something new. So from this is what Alyssa mentioned, is that, basically First Year Cleveland said, we would like to be able to go to the MCOs with this argument that this is a viable way in which to impact food insecurity and perhaps prematurity. And so at that point, the CTSA had provided some funding for basically the food bank and Better Health Partnership to get together and develop a program plan. And then we became partners as part of the research infrastructure. And that's how the three partners came together. And then for really about 18 months, these three partners worked very hard on developing not only the program that Alyssa's, has already talked about the basis of it, but then building the study of it at the same time, which those of you that are evaluators in the call today understand that this is the ultimate way to do this, right? And you do it from the beginning. So we started out by the partners basically co-designing the shell of the program, and then we brought in CHWs for their input on all aspects of the program. So they're the ones that are actually engaging. They know the clients, and then they also know the process in which the hub works too. So it helps us a lot to understanding how to make this a sustainable program. So they gave us feedback on recruitment and delivery, even measures, and then on the impact. And they continue to be engaged in the ongoing development. And so the aim of Nourishing Beginnings is really to address the negative effects of food insecurity during pregnancy by both integrating and streamlining this referral system that comes in through the hub and with the food delivery systems to be able to increase really quick access. Because one of the issues we also know is that there's a lot of referrals going on, but the time from a referral to actually getting a resource can be quite lengthy. And in pregnancy, food is a very timely thing. And then the second thing is, as Alyssa alluded to, is that we really believe that the community health worker themselves play a very integral part of making this intervention work, as well as wrapping other support for the pregnant individual and meeting the other unmet social needs. But as Alyssa mentioned, ultimately our goal is to determine if Nourishing Beginnings will improve maternal and baby health outcomes, which, in reality does that affect health care costs? And if it does, then it may lead to this reimbursable path for direct food access in the future. And so just as a bit of a background then, and I will tell you we'll talk about the study design in and out of this seminar, and you can ask later about more details, but it has morphed. We started out with a very small pilot because the funding kind of has grown over time. So what we're telling you now is kind of where we are today, but it has been a slow process. We started out thinking we would get about 80 clients, and now we're up to, with the new funding, so for the study itself, we'll have 160 individuals recruited, and they have to be referred to the hub first. And those referrals come from all over the place, from other, from managed care organizations, from clinics, from physicians, as well as what we are encouraging a lot is the actual CHW outreach, as well as any of the referrals that come in through the food bank. So it's sort of this idea of coming into the hub from multiple places, and the earlier the better. So for reasons of the eligibility, they have to be 18 years or older for the study. They have to be pregnant. They can't be any more than 22 weeks. And we have chosen that as an inclusion criteria because we want enough time for the intervention to have an impact. English speaking, but remembering that in the hub, all the population is Medicaid eligible and low income. The CHWs come from, like Alyssa already alluded to, come from a large number of community organizations and health providers. And then, as we're going to tell you a lot more about, there's actually two intervention arms to this. One is the food box delivery from the food bank. And then we also are trying a second arm that is a financial assistance. And we'll tell you a little bit more about why. We do not have a traditional randomized control group, but rather, and we can talk more about it, but it's more for the reason of the partners and particularly CHWs, the idea of withholding something from a group didn't seem appropriate. And so we are going to be pulling our control group samples from two different comparison groups. One is a historical control group of individuals that were in the hub prior to the intervention launch. And then the Care Source, one of the largest managed care organizations, is going to be providing us a matched control group of individuals pregnant during the same time. So we'll be able to look at outcomes that way. And so basically this is our design, is that the overall population are Medicaid eligible pregnant individuals. They are then either, if they become part of the hub or not. And so this becomes truly our population. So it's not all Medicaid individuals or pregnant individuals, but those that come to the hub. And then of those that come to the hub, they are recruited to be in Nourishing Beginnings. And then at that point, they are randomly assigned to being in this food box group or the money and navigation group. And then there's a match control, as I mentioned. And this is just for all those that know me on the this is the kind of visual to me that helps me understand. And for those of you that think in this way. Let me just go through it a little more quickly. Our obvious hope and goal is that we want to look at these interventions both together against the controls as well as against each other, primarily to these birth outcomes, because these are the outcomes we have on everybody, including the prenatal care, because this is the information that will come from the MCOs. But then as a part of the study, we have also included a number of more what we would call intervention targets or mediators that might help us to better understand if we have outcomes, how in which those outcomes work. And those are things like food insecurity itself. You know, does it in fact reduce food insecurity? What does the diet look like? And is there changes in the healthy eating as well as the different nutritional components? And then a whole host of psychosocial factors that we know strongly that food insecurity is highly associated with these individual things. And we know that they are also highly correlated with prematurity. And so our goal is to understand both, does the intervention impact it? And then does it mediate any of the outcomes through them? One of the things that we believe is that it is the CHW themselves that we believe will have the largest impact on the psychosocial. These other things, we think the interventions, it's going to be the food and the money that will probably change these things. But these are probably more likely to be impacted by having a trusted individual with you during your pregnancy and also providing extra support. So we're going to look to see how that has an impact. You'll notice that we have brought in reports of racism. We are asking clients about both microaggressions and basically the institutional racism they might experience through the clinical encounter during their pregnancy. Because another hypothetical or another theoretical thing we want to look at is, does the CHW help in that factor anyway? We know from CHWs that they often will help individuals navigate different situations if they feel like they are not being supported. Okay, so I'm going to now flip it back to you, Alyssa, and take it through the intervention arms.
Great, thanks, Elaine. Okay, so moving on to the next slide. I'm going to talk a little bit about the food intervention part. And actually, this first slide, both interventions are receiving. So we did a little bit of market research, so to speak, to see what types of initiatives that are similar are going on across the country. And there's some work happening out of St. Louis that we connected with their team, and they told us that they found through their experience working with a similar population that cooking tools and cooking readiness were really issues in the community that they're serving. So we kind of copied this little bit from their work and included a cooking tools assessment for both groups. So we have budgeted for every participant about $100. But I do have to say that from the surveys that we're receiving, people need more than $100 worth of tools. So that's definitely a lesson learned. So when everyone is enrolled, they go through this cooking tools assessment with their CHWs. I'm seeing a lot of need for basics, plates, bowls, silverware, mixing bowls, baking sheets, skillets. I have a lot of people requesting slow cookers. And then we're seeing a fair amount of need in the freezers and microwaves and ovens and things as well. So for those things, we don't have the budget, but we do make connections to other community partners who are able to connect them with those appliances. Next slide, please. The food delivery arm, the goal here is to reduce the stress of shopping and food selection and improve nutrition, self-efficacy through food. So what this intervention looks like, it's 1 week's worth of food, and we have some guidelines and criteria on how we define that week's worth of food, all of which comes out of the USDA. We're home delivering it every other week based on the preferences as submitted through a food preference form. We also have recipes that we send with every box and nutrition tips that are tailored to pregnancy. So we have a curriculum that we've built out. I have a registered dietitian on staff and actually a regular supply of dietetic interns as well that have helped us to build this out. So we have week 1 through week 20 of nutrition tips that are targeted to pregnancy and then coordinating recipes. So we send those with the box as well. In addition, we send a pantry staple box that has ingredients like olive oil, spices, vinegar, some condiments. that go out about every 7 weeks. And then in addition, we'd send text surveys a week after the boxes are received that ask just a couple of questions as far as how much food in the box did you eat? How satisfied were you with the food? Is there anything that you'd like to see done differently? For example, things that you don't want or things that you really liked that you want more of. Next slide, please. The food preference form is a really important part of this intervention. It's done typically at the same time as the cooking tools assessment, but it's done with the community health worker. And we ask a lot of questions, things like, do you have allergies? Do you have diet preferences? Are there specific foods that you do or don't want? Also very important, we have 3 delivery windows. We're currently delivering Wednesdays, so today actually, from 4 to 6, Friday morning from 9 to 11, and Saturday morning. So we tried to stagger those delivery times so that we could work with a variety of different work schedules. We ask people whether there are other people in their household who are approved to accept the deliveries. Whenever possible, we want someone to be there to accept it. Either way, we always receive confirmation that the food's been accepted, because sometimes people will request a contactless delivery. And we text people to confirm before every delivery. So there's initial confirmation to confirm all of the preferences, that the address is correct, that their food delivery window is correct. And then additionally, about 24 hours before the deliveries go out, we confirm that someone will be there. This slide shows an example box contents for one box for a family of 4. And again, this is meant to be 1 week's worth of food for a family of 4. So we do tailor it by family size. So if there are only 2 people in the household, it would be fewer items than this. We are striving for about 50-50 perishable versus shelf stable. And some of that comes from feedback from community health workers that there is limited space, both on shelves and in freezers and refrigerators. So we're trying to do about 50-50 down these 2 categories. We get a pretty good variety of food through the food bank. We're always looking to make things low added sugar, low sodium, but provide a high variety. And then the recipes that go into a box like this, some steamed cabbage to show people how to, ideas for how to use some vegetables, lentil soup to use those dried lentils, and black-eyed peas recipes, and turkey meatloaf. We have a couple of pictures of the boxes. These are actual boxes that are going out. It's actually a couple of boxes of food. We have 1 box with the perishable items. We have 1 box with the shelf-stable items. There will typically be, in addition to that, a bag with frozen proteins. So in any given delivery, someone is receiving at least 2 boxes, and then 3 if they have the cooking, the pantry staples items as well. Next slide, please. This is an example of a recipe that we send. We've demoed this through our dietitian at a number of different feeding sites. It tends to be a pretty popular recipe. And moving on to the second intervention.
All right, Meredith. Uh-oh.
Sorry, I was muted.
Okay.
I'm going to tell you guys a little bit about that second intervention arm. So as we mentioned, originally this project was born to do home food delivery, but we were not able to have a pure control group that wasn't receiving any additional support, that just wasn't tolerable by our community partners and by the community health workers. So we developed a second arm, which was designed to be fairly comparable, but provide different and act on some of those same intervention targets, but through a different mechanism. So this is a financial assistance and healthy food navigation arm. And the goal of this was to provide additional financial support so that they could purchase on their own healthy foods during their pregnancy, and to reduce through the navigation, to reduce the stress of finding that healthy food near them, ultimately to improve their nutrition and their self-efficacy with food also. Now, I will say there is no stipulation for these participants to have to spend their dollars on food. We do not track it, but we do encourage it. But like I said, if reducing their stress comes in the form of paying their gas bill, that's up to them to spend it however they want to do that. So what we do for this arm is we provide $30 every other week and it is deposited directly to Cash App. We didn't want to use gift cards. It just wasn't really feasible. We didn't want to ask clients to provide banking information so we could do deposits through Zelle like the university offers. So we came up with Cash App as an acceptable alternatives, and the CHWs we were working with really thought that this would be an appropriate and really accessible option for their clients. And in fact, I will say out of the 17 people so far, 16 of them have already had existing Cash App accounts. Only one person that came into our study didn't have one. So the community health worker works with that person to create and open a Cash App account with that client. So the nice benefit about this, Alyssa was mentioning these pathways, that also for the community health worker counts towards a financial, my Better Health Partnership friends on the call, I'm going to get this wrong, but it helps towards a financial pathway also, which would be a reimbursable service for the community health worker. So they set up the Cash App with the client. We deposit $30 every other week. And then they do this navigational support, which I'm going to talk about a little bit more in detail in a second. We also, in lieu of the recipe tips that are coming from the food delivery, we give them a cookbook at the beginning that has easy recipes for them to follow. And they are reporting using that cookbook and following some of those recipes. They too get the $100 in cooking supplies. And we are just beginning to roll out providing those same nutrition education tips to the clients that hadn't originally been part of the intervention, but we really feel like that would be a good addition. So as we're moving forward, we're beginning to figure out how to get those nutrition education tips to the clients as well. And similar to that first intervention arm that Alyssa described, they are providing regular feedback as well about their satisfaction and their utilization of their support through this intervention arm. So they're getting a survey from the food bank every other week, a week after their deposit was made into their Cash App account, which asks them about how they spent their money, which asks them, was it easy to access? Did they make any new recipes? Those kinds of things. Next slide.
Meredith, before we go to the next slide, do you want to mention why it's as low as it is?
Yes, thank you. So we know that this $30 is not equivalent to the food, that the amount of the cost of the food that they're getting. However, there are tax guidelines, tax restrictions that clients cannot get, participants in research cannot get more than $600 in a calendar year before they have to report it as income. So if we were to provide them more than $600 in any one calendar year, we would have to issue them a 1099. And that reporting of income could also impact the client's benefits, their SNAP eligibility or anything like that. So we had to keep the amount we're contributing to them financially under $600. So this was the maximum we could give them. We also do pay for data collection. We don't really talk a lot about this today in the presentation, but we are providing them when we do data collection some financial incentive to complete their data collection. So their biweekly cash plus their data collection in total had to be under $600. So this was the most we could give them. So thanks, Elaine. Okay, so the healthy food navigation is an integral part of this intervention arm too. And for that, we're using Fresh Finder. And Fresh Finder is an interactive map that was developed by the PRC to help health professionals who are working with clients locate those healthy food options nearby. We did a whole presentation on Fresh Finder last year. So feel free, if you're interested and want to learn more, you can definitely ask, but you could also go back to the presentation we did last year. So every summer we have a group of interns that go out into the field and do what we call a food retail audit. They have a list of all of throughout the entire city of Cleveland, all of the locations that sell food, and they go into the stores and basically find out what's inside and complete this audit tool. We won't spend a lot of time here, but it populates this map, and the map can be used so that anyone working with their client could type in an address. It pops up all of the food retail locations nearby, and each of those icons indicate what class really of a location that is. Is it a large grocery? Is it a small grocery? Is it a corner store? And you can actually click on the Fresh Finder map and pull it up, and it'll tell you it contains dairy, it has formula, it has this amount of produce. So it's a really nice tool that has been rolling out. Elaine's putting the link to this in the chat.
Actually, I'm not, because I'm in present mode. But
we'll get you to the link in the chat here.
Actually, if anybody just Googles Fresh Finder, it comes up typically, and it's on the PRC's website. It'll take you right to the page on the PRC website.
Yeah.
Okay.
So,
All
okay,
right.
you can go through.
Yeah.
So I'm going to move on and talk a little bit about the data sources. So you saw the model that Elaine shared with you a few minutes ago. So we have all those outcomes that we're interested in looking at, and we're also looking at the potential moderators and mediators for how the interventions are creating the outcomes. So to do that, we're looking at a variety of different data sources. The first one, and probably one of the most significant ones, is the data that comes from the Pathways Hub. And one of the reasons why they're such a critical partner in this model is that they routinely are collecting this data on all their clients. So when someone's enrolled in the hub, there's a really intensive intake process where they collect a lot of data about the client, about their needs, that kind of thing. Those data are used for us for the background demographics for the client, whether they've had children before, what their household status is, things like that. That's also where the community health workers document their delivery of their services. So when they have a monthly visit with their client, they're documenting that all in the hub system, which is called CCS or Care Coordination System. They document all of that there. So from that, we can find out about the interactions the community health worker is having with their clients. And lastly, the maternal and infant outcomes come from Better Health Partnership. They're self-reported to the community health worker and in CCS that way. And additionally, Better Health is able to verify those outcomes with the managed care organizations. They do that as part of their billing process too. So Better Health provides a lot of the data that we use in the study. In addition to that, we're collecting some data directly from the participants, and we really do this at 4 different time points throughout the study. So initially at baseline, there's a host of things we're collecting. We do at 10 weeks after they've started getting their intervention. So they enroll, we have some data collection, and then they have a start date for the intervention where they get their first food box delivery or they get their first cash deposit. So 10 weeks after that date, we assess these things again. And then at near delivery. So we try to catch them right before they deliver. So around 36 weeks, 38 weeks, we're trying to catch them. We have missed a couple and had to do it immediately after delivery when they've delivered early, but we're monitoring that and trying to catch them right before they deliver. We just had a community health worker say, hey, I know someone's getting induced early. Let's make sure we get it. So we sure enough got their data collected before they were induced. So this parent survey that we're collecting directly from participants, that's where we're finding out about their self-report of food insecurity and all the psychosocial measures, which I'm going to describe more in a second. In addition to that parent survey, we're collecting the nutritional status by using the NDSR, which is a 24-hour diet recall. So we are trying to get an NDSR at 3 different time points: at baseline when they're starting, close to delivery, and then at postpartum, 6 months postpartum. And we're looking to see if there's any change in nutritional intake at those time points. We are using the gold standard protocol with 3 calls at each of these time points to average the recall information at each time point. And lastly, Alyssa and I both mentioned that there's some text survey data about their satisfaction. And there's one thing I'm remiss not to mention too. At the time we're collecting the NDSR, we're asking them questions also about their satisfaction with their community health worker. So we're asking the client about the nature of the relationship with their community health worker. You can go to the next slide. So Elaine showed you this model a few minutes ago, and I just kind of put it here again to orient you to where these data are coming from. So if you look at the right side at those outcomes, a lot of that is coming from the hub data. And that bright blue box at the top in the middle column under the proximal outcomes, that too is coming from the hub data. The lighter blue data are the data that we're collecting specifically for the purposes of evaluating the intervention. And that's being done through the parent survey and the NDSR. Go ahead, Elaine. So on this parent survey, what I mentioned that we're collecting at these 4 time points, it is done through REDCap. And we basically have assembled several different individual instruments and made it into one bigger survey. It is a little detailed and in-depth. We've worked with our community health workers to really try to get the most information in the least amount of burden we could. So we worked really hard with them to pick the depression indicators we're using, to pick the race measures of race that we wound up using. I know we're running out of time, so I'm not going to go through all of this, but there's a lot on here. Okay, so I just wanted to tell you quickly too where we are. So we kicked this off in very, very end of July, beginning of August with our very first client. And it was an intentional, slow rollout. We really wanted to take one client all the way through the enrollment process, see how everything worked, get them set on their intervention, make sure things were going okay before we kind of started enrolling more. And then we really did go very, very slowly. The community health workers were really only onboarding one client at a time at the beginning. So just now, I feel like really at the end of 2022, did we start kind of picking up our pace a little bit. To date, we've had 17 clients enrolled, 9 in the food box and 8 in the cash assistance. We've already lost 3, unfortunately. One moved out of Cuyahoga County and she's being referred to a hub down there. She'll no longer be able to be part of our program because we're limited to Cuyahoga County, but she had already had her baby. So that's the good news. She had a baby. We have all of that data, but we won't be able to follow her into that 6 months postpartum. And then unfortunately, we've had 2 that were lost to follow up that just no longer were responsive to their community health worker. Phone numbers changed. We can't reach them. So we're no longer in contact with 2 of those women. We have had 4 babies born. And as far as looking at where we are with community health workers, we currently are working with 3 agencies, and another agency has been partnering with us kind of all along, have been part of the early design conversations, but didn't have any community health workers participating, and they're coming on with community health workers soon. But what we've noticed is there's a lot of turnover at the community health worker level. So we have had 3 already leave and have to get replaced with new community health workers. So that has been a little bit of a barrier. Go ahead, Elaine. And really quickly, we are running out of time. I'll be happy to tell you more about this, but I guess most notably on here, the large majority, over 3/4 of our women enrolled are African-American, and our average age at enrollment is about 18.1 weeks. Most of the women are on WIC, and just under half were on SNAP. Go ahead and go to the next slide. Food insecurity was surprisingly a little more secure than we anticipated. We had 43% saying that they only scored 0 or 1 on food insecurity. But I think out of I think it was 5 of the women scored in this range, or 7 women scored in this range, 5 of them were on SNAP, which probably bolstered their food security. And with the SNAP dollars decreasing, I'm expecting that to actually impact that. And the healthy eating index score was pretty low. It was 43.9. So go ahead, Elaine.
No, I think Alyssa's going to start us, right?
Okay, sorry.
Sure, yeah. And so we have had some challenges, but dare I say that working through these challenges with our team has been very satisfying. So having such great team members and so much great knowledge on the team has made working through these, a very effective process. As Meredith said, there was slow enrollment initially, which was intentional, but the slow enrollment continued on a little bit longer than we wanted. So there's been a lot of time and effort put into training more CHWs, and growing those relationships and working with agencies to see what types of additional support they need from the team. The data collection and just making sure that everybody knows when to collect the data for each of their clients, all of the coordinating that requires, that has been something that we've worked through as well. So Meredith could provide details to anybody about all the steps that they're taking, primarily through REDCap, to make sure that there are automated reminders built into the process. There is a perception, I would say, of administrative burden from the CHWs with the data collection. And so, that has been one of the bigger issues, is making sure that CHWs are comfortable with the data collection itself and the timelines associated with that data collection. And then building a primary person to communicate with the CHWs. There are a lot of logistics with this program and implementing it. And we have found, especially from my perspective for sure, that our communication needs with the CHWs around little details like, I can't reach somebody and we're supposed to deliver to them tomorrow. Do you have the phone number is not working? Do you have an extra phone number for somebody? Or what to happen when we're hearing that somebody moves, for example, what's the new address? So there are just a lot of little things that pop up that we're requiring communication with the CHW on a very regular basis. So making some of those processes smoother is going to improve the study as well. And I know I raced through that. I just wanted to make sure there's time.
That's good.
Yeah.
So I think I'll end it and we're very, very grateful both to Vitamix and to Burning for giving us our foundational funding. And then one of the reasons we really were pushing for additional funding was just to address some of these things. So we did receive a very large grant from Robert Wood Johnson that really solidifies the grant or the study. It allows us to do a fully powered now a study of the impact of the program, as well as hopefully pulling off some of the data collection burden and cost onto the Robert Wood Johnson funding so that we can use the other kinds of funding to support the rest of the program. But really importantly, CareSource of Ohio gave us a quite generous grant to basically support the grassroots organizations that provide the CHWs. And so now we will have additional funding to support these organizations, to support individually the CHWs, as well as to support having funds to support the participants and the clients with non-financial incentives, not incentives, but this idea of that 10-week to the follow-up is quite a long time. So now we're going to end up using the funds to buy things for once the baby comes. So there may be those kinds of items, whether it's diapers or things like that. So I think that all of this has really energized all of us to think, okay, we really can do this. We probably are going to do a bit of a reboot and put all these pieces together. I don't know if Meredith wants to wait to the discussion, but a lot of this was looking at the burden of data collection also included getting all the consent. And those of you that do this work know the consent was being read word for word. It was taking almost 2 hours. And so that, we're happy, and Meredith can talk a lot more about that. After a lot of work, that is, going to be greatly reduced. So I think that's, I think we can probably move on from here, you guys. Let's open it up to questions. I mean, we're going to continue. The Robert Johnson gave us some really support to do really strategic QI analysis, which if those of you that know Chris Mundorff, that the QI process is something that they do very, very well at Better Health Partnership. And so we will learn a lot about not just the outcomes, but all of the implementation aspects of the program, so that if it is sustainable and can move on to the rest of the state, for example, then we have the mechanisms to show, where those failure points are and things like that. I think we can say thank you. I'm going to stop sharing and then open it up to questions.
Thank you so much. Oh, go ahead, Meredith.
Let me say one thing. I just want to say, I love this project. All of us who work on this project really love this project. And Alyssa said it. I love that we're helping women. I love having met and get to work with these community health workers. I hadn't really known a community health worker before this, but I also love this team and all these people that we're working with. We meet very frequently. We spend a lot of time on Zoom together. I know some of them are on this call.
Hey, Jonathan.
All the people at the food bank and at Better Health Partnership, it's just been the greatest, most productive collaboration I've been a part of. So just want to publicly tell everyone, thank you.
Yes, no kidding.
I'll second that.
Well, thanks so much to all three of you. This is a special team and a special project, and and important in so many ways. So I'd love to open it up to the audience for questions. Again, you can put your questions into the chat, or you can come off of mute and turn on your camera and engage directly. We love to see everyone who's with us. I like seeing people come on camera.
Yeah.
Okay, so we have a question in the chat. Are volunteers needed for the project?
Alyssa.
Volunteers are critical to food bank operations in general, but we are using volunteer delivery drivers. And in fact, we need some more. So if anyone's interested, we are looking for drivers, in particular for our Wednesday and Friday delivery time slots. The Wednesday deliveries are 4 to 6. So sometimes that's just a little bit, we do have a couple of volunteers delivering regularly at that time, but when they're not available, we really could benefit from a couple more. We have a ton of delivery drivers for Saturday. So if anyone, Wednesday 4 to 6, Friday 9 to 11.
Alyssa, should those folks reach out to you? What's the best way for them to get in touch to volunteer?
Yeah, I'll put my email in the chat. You can
Fantastic.
And we have just a little bit of paperwork. We do make sure that people are approved to drive, and we do a background check, and that's a pretty quick process. And then we can get you out there driving.
Fantastic. A related question, perhaps, that I will just ask, knowing that we do have some students on the line. Are there opportunities for students to do some engaged learning or be a part of the team for you all? And if so, how should they contact you?
Yeah, so we can say from the research side of it, we already have a number of students that are part of our project. And obviously, if it weren't for the students, we wouldn't have the Fresh Finder part of this at all, right? But yeah, I think you can reach out to Meredith or I, or Laura Fernandez is on here too from the research side. I don't know, Alyssa or Jonathan, if there's any room for students from your side.
We're certainly happy to take student volunteers. We can use volunteers at our Euclid neighborhood pantry. That's where we're packing boxes. So any help at that pantry and to help pack boxes. I would love to have some regular volunteers who are comfortable with nutrition labels so they can help us identify the right ingredients to put into the boxes. So that might be a really nice opportunity. And as I said, we have some interns that come and work with the food bank to help us create, new and fresh recipes and contents to put in the boxes.
Fantastic. I see both Alyssa and Laura's contact information in the chat. So for those of you interested, go ahead and jot that down and reach out to Alyssa and Laura with your questions. I see Jen's hand up. So Jen, I'll ask you to come off of mute and ask your question.
Yeah, thank you so much. And thank you to everybody for this wonderful presentation. I learned so much, and it's very exciting to see this in this presentation. So yeah, thank you. So my question was, I was struck by when I was listening about the two arms, I was struck by, I'm sure this was very intentional, it was the stress of, the goals were to address the stress of food shopping and the stress of, what was it, locating healthy food retail outlets. And I'm sure this was super intentional, but I wanted to know about kind of what led your team to say you want to address the stress of those components. How does that differ from other types of stress, or like the stress of, is it separate from the stress of food insecurity, or how do you, maybe I'm reading into it too much, but if you can say a little bit more about that,
I think, Meredith and Alyssa, you can jump in too. I think that we know, for example, that if you work backwards from the health outcomes, we know stress up from all different things. Right. So it's not just from being food insecure or living in poverty, but it is also not having access. And, we've talked about, one of the programs we talk a lot about is like WIC. WIC ought to be really easy to use, and it's aimed for pregnant, but folks have to actually physically go to the appointment, every, quarterly. And so, you're talking about somebody getting on a bus, right? There's just a lot of stress that's involved in just locating access to that food. So our measurement for stress is a bit more generic than that though, right? So because what we believe is the mechanism, we all know this from just chronic stress, right? That if we believe that the chronic stress is underlying these health outcomes, that any reduction in the two intervention arms has the potential of reducing that. And as Meredith said, yes, the money could be used for food, but if they pay their electric bill, if it allows them to pay their electric bill, then that also may reduce that stress. And so, a lot of this is mechanistic, and we're not quite sure. Well, hopefully we'll be able to have some insight to it.
I would add to that. I remember an early conversation with a community health worker. They do a lot of mentoring and coaching and supporting their clients, and being able to have a conversation with them around the navigational piece. Like, okay, I know you have another child and I know you don't have a car, you need to take the bus. So let's look at the map and see if we can figure out how you could get, somewhere closer so that you could get some fresh fruits or vegetables. So, I think there's just so many barriers sometimes in front of these women. So reducing any one of these barriers around the logistics of getting their food would help speak towards that stress that you brought up, Jen.
Thank you. Just to clarify, I really appreciated the framing of that. And I don't think I've seen it kind of put up like as a goal. And that was the impetus behind my question. So yeah, I really appreciated the framing. Thanks.
Thank you.
I was reminded to remind you all, we have two brand new websites finally, that communicate about the project. One is hosted on the PRCHN website. If you go to our work tab under the PRCHN and the community nutrition piece, you'll find a whole page there about this Nourishing Beginnings and see this model firsthand. And then Better Health Partnership, our friends there just added a page that is really kind of a little bit less research focused and more broadly focused about the program and how to get involved with the program. So I was hoping, did someone, I think, may have put it in, but we're going to try to get the link to the Better Health webpage. Yes, he did. Oh no, I think I can do it. We're going to put it in the chat too, so you could check out their website as well.
Thank you, Meredith. And Laura, maybe you can put in the PRC website into the chat for everyone, be able to have access to that. Tabitha, I see your question in the chat, and I also see you with your video on. So I wonder if you'd like to come up and mute and ask your question in person.
Sure. Again, great presentation, great information. Love the program. One of my questions was just about referring mothers to the program. Is there a certain process, or is the program full to capacity at this time?
No, the real thing though is that the referral has to go in through the hub.
Okay.
So the referrals, that's what we say, the referrals can come from many different places. So like, I don't know, Alyssa might be saying one option is to go directly to Alyssa into the food bank. And now that can get you directly into the hub. But a CHW has to be a part of the hub in order for the pregnant individual to participate.
Okay, because I work for Ohio Rise, and we have a benefit for mothers. It's like a Maternity Matters, which we give them like a gift card. But also with them identifying that they're pregnant, this would be a great tool for some of our care coordinators to refer them to this program as soon as possible. So that's why I asked. I just want to make sure I give them the correct information so that they can start referring our members.
So we can connect. Go ahead, Alyssa.
So I put a link in the chat that you can use that has the email for our root cause coordinator, and she's able to refer directly over to the hub. You're always welcome to email me. There's no wrong door at the food bank. They'll find me eventually. That's probably the easiest way because we have that tight connection with the hub.
Yeah.
Thank you, guys.
Thank you.
So glad you're on the call today, Tabitha. It's a great question, great connection.
Glad to be here.
I have a question about the turnover of the community health workers. And in thinking about that turnover, how much do you think that is that fairly easy to overcome? Or what's the feasibility of the sustainability with that turnover, given that some of these skills really are inherent to what community health workers come with? And how are you thinking about addressing that long term?
My partners from the Better Health on this call are far better poised to answer that question. So I'm going to take a stab, but if any of you all that are on here want to turn on your camera and jump in. It is not super easy right now to overcome that, I'll be honest. So working through the hub requires quite a bit of training for the community health workers to learn how to use the hub processes. So that is how they collect data in the system, what data need to be complete for intake, and et cetera, to get reimbursement. So there's kind of an intensive onboarding to the hub itself, and they need to kind of get used to what that system's like. So whenever we've gotten a brand new community health worker that hasn't been part of the hub, they have to go through this onboarding to the hub first, which takes a bit of time. Then once they're comfortable, there's a training for Nourishing Beginnings where we teach them about the data collection tools, the consent process, the overall study design. And that's, a significant amount of work. All the community health workers have to be CREC certified, so that there's a process for them to have to get CREC training, CREC approval. They're not doing city training. They're doing something called certification, which is aimed towards community members doing research. So it is a lot to get a brand new community worker up and really running in this. So that has been a major stumbling point for us so far. Our hope is by providing, there's lots of reasons why the turnover is happening at the community health worker level, and we're beginning to try to figure some of that out. We're hoping by supporting the agency more, that trickles down to supporting the community health workers, and that will help retainment too.
I would just add, these are very stressful jobs. I mean, they're supporting people in an enormous amount of social and other types of needs. So I think our whole team has a new appreciation for what it's like to work with people on that level, and B, for many people, their only source of stability and support. So as Meredith said, I would just echo, like, trying to provide more resources for the agencies so they can look out for their community health workers is going to be a really important part of the picture.
And the hub is doing that also. I mean, they have their own hub-wide efforts to support the community health workers. And so what we're talking about is just the extra ones we're doing for Nourishing Beginnings, but the hub actually is really taking that on.
Any other questions for our presenters today? Again, please feel free to come off with mute and turn on your camera and engage with our team.
I have another question.
Yeah.
Have you guys considered fathers, or is there any inclusion for any single fathers, maybe if the mother has passed or is not in the picture?
So the study itself is the outcomes really of the mom and the baby, right? So I think that is a little bit of the, but clearly if they're in the household, then they're a part of it, right? But I mean, I think that the aim is really about, trying to improve, like we've been told, now we'll see if this actually comes true, but we've been told that, even if gestational age at birth went up 2 to 3 weeks, if birth weights went up, that a very small amount of an improvement on those things has significant outcomes, not just healthcare costs and things like that, but just in terms of future, that 1 year's life of that baby. And so the focus is really aimed there, but I understand your question. I think that they come more in the process of the intervention delivery and what if they're a part of it, but they're not a target necessarily.
I will tell you that has creeped into many conversations over the last 2 years about wanting to support these women and engage these women throughout that whole first year. And we have other research people that are interested in that. We just can't get there yet. We've got to get this launched and successful and with the focus it has right now before we start thinking about the wraparound side of that.
Yeah.
But it's a great,
but it's a very good question.
Point.
Yeah. I'm surprised no hard research questions. This is good.
Jen?
Yes, may I ask a question that Tabitha's question made me think of, which was it sounded like for the food boxes, that's adjusted to the family size. So if it's a household of 4, they get a certain amount of food. Yet the Cash app, there's a limit to that. So how are you, are the arms equivalent, and how are you accounting for potential differences in those 2 arms?
We don't know yet. I mean, in some ways you can also assume that the Cash arm is a control too, right? So it doesn't necessarily have to be equivalent, but there's no way around it without harming the potential of the services that the clients can receive if they receive too much money. So we've looked, what I don't understand is we feel like there ought to be some sort of a waiver that could be sought, right, from IRS, so that we could provide individuals with more money than the $600 and it not harm their benefits. But at this point, there's really no way. Oh, Alyssa, it's at least should be at least double, but that would not be possible with the restrictions we have.
Yeah, the last thing we want to do is have somebody lose their SNAP dollars. So
yeah,
we're just doing the best we can, but it's a very fair point.
Yeah. I mean, hopefully we'll be able to do a little bit more with the non-financial stuff now that we have that funding as well. So hopefully they're, but it's not the equivalent. It's still not the equivalent, right? That's, yeah. Analytically, we're not sure, although, like I said, I think we'll see when we compare them against each other, but it'll be very interesting to see when we compare each of those against the controls. That's how we'll know a little bit more about the impact of either one.
Interestingly, in the food group, I think we only have 1 family that has a household size of 1 or 2. So most of the people are falling into the 3 or 4 category.
I have a little bit of a related question, and I'm paying attention to the clock, so I'll try to keep it brief. I think you said when you were describing the sample that it was only about 43% that are on WIC, and that
on SNAP. That
okay. But that's pretty low. And I think I heard in there that there are some administrative challenges that keep people from engaging with that more,
Yeah.
and getting to appointments. And so, you know, I imagine that in the policy development way back when, there was some sort of, we need people to show this level of commitment in order to get this benefit. And I wonder if you think that long term, even this program might go that pathway, that there has to be some sort of showing up. And does that sort of make, I don't think you're doing that right now, but right, these other programs were meant to sort of do that. And I wonder if this is just, you know, if they had WIC, if there was different, you know, access, would this really be needed? Or is this sort of circumventing the administrative burden of WIC and really addressing the need that people have?
Alyssa, you're probably the best one to answer this.
I guess we wouldn't know until it became easier to use. I mean, the burden of utilizing WIC is pretty well known, and there have been a lot of people begging for a lot of years for the state to make it easier to use. So right now, to reload your card with WIC dollars, you have to go in person and swipe your card or have your card swiped every 3 months. So for people who are pregnant and working and have young kids, it's very difficult to do. So I don't know if the quantity of services provided through WIC were a lot easier to use, there would probably be less need, but that's only one part of the difficulty in using it. There's also restrictions on what you have, what's available to you, and the sizes of various foods and the types of various foods, and not everything is labeled. So I think in a perfect world, WIC becomes much easier to use, and maybe these types of programs are less needed.
So Eric, I thought you were going to ask a different question, because one of the struggles we do have is that we're getting these baseline data are prior to really the CHW working with the client. And so along the way, you know, we may get to the 10 weeks and find out that now we have 80% WIC and 80% SNAP. And so now they've got more access to food, right? Yeah. So we're going to have to control for that, which, you know, because that's obviously part of those unmet social needs.
Right. So I was just going to highlight that too, Elaine. You know, what we didn't really stress in describing the intervention, just out of a lack of time, is that what the community health workers normally do is part of that as well. So the community health workers are addressing all of those things. They are addressing SNAP and WIC enrollment with every pregnant client they have, making sure they can try to help them get signed up if they're not, et cetera, et cetera. So all of those things are happening too. And we just kind of showed you the add-on layer of what Nourishing Beginnings provides. So Elaine's point is exactly right. We're going to see potentially an increase at that 10-week post-enrollment, hopefully, or maybe not. And that will be interesting as well.
Thank you. Well, I've taken us to our 1:15 mark, and I want to thank all of you who've stayed with us throughout the questions. I want to again thank Elaine, Meredith, and Alyssa for this wonderful presentation. This really important work. We will probably ask you back next year, because we just love hearing about this project and love giving updates on this. It's an important topic. I want to let you all know that there are several important web links in the chat, so please make sure to grab those, as well as Alyssa and Laura's email addresses if you'd like to reach out to them directly. We've also posted the link to register for our March PRCHN seminar series, again featuring Dr. Georges Khalil from the University of Florida. We hope that you'll join us again for that important presentation. I invite you all to come off of mute and come on camera and give a round of applause to our presenters. And we will look forward to seeing you all again soon.
Thanks, everybody.
Thanks, everybody.
Good to see all of your faces. Take care, everyone.
Bye.
Thank you.